Convener, I've no formal apologies. I don't know if you do, Brian, direct.
Suzanne Thompson.
Apologies
from Suzanne.
All right, fine.
That's great, thank you. And do we have any declarations of interest? None, thank you very much. So we'll start with the minute of the previous meeting from the 21st of May. Does anyone have any comments or corrections they would like to make? Hands up if you do. If not, are we happy to approve the minutes? Yes, thank you. That's easy. Excuse me. And I'll just move on to the rule and action log. I see that anything in relation to current actions are within the meeting today, in terms of Bunbury Care Home and the hospital acquired infection performance report. So I don't know if anyone has anything they'd like to ask or questions around the role and action log. Patricia.
Sorry, it was just a comment. We've had an inspection, a follow-through inspection at Bunbury last week, and if the committee are happy, Martin can give an update on that when it comes to the appropriate report. Thanks.
That'd be great, thank you, Patricia. That'd be really helpful. Okay, let's put myself a wee note of that. Right, so the next part of the agenda is a presentation on medicated assisted treatment standards. So we'll have the presentation and then there'll be 10 minutes or so to ask any questions that you might have. And I believe I've got Ross and Elaine who are presenting that.
Good morning. Yep, we've got the presentation here. Elaine's going to start us off, but I'll just try and share my screen first and do the usual test of can you see it and all that kind of thing. So can you guys see that okay?
Yes, thanks, Ross.
Sure. And has it moved to a full slideshow mode, or are you still just seeing it with the boxes down the side?
It's not in full slide mode yet.
Okay, we'll just go with the boxes down the side, provided you can all see that okay then.
Thanks, Ross.
Oh, it's shifted back to your
There we
email.
go.
That's it now.
I rescued it again. Okay.
Yeah.
Well, fingers crossed that'll be fine. We'll get slicker as we go on, I promise.
Thank you, Ross. I'm Elaine Lawler, Alcohol and Drug Partnership Coordinator for both Alcohol and Drug Partnerships in Forth Valley. And it's really good to be able to present on the medication assisted treatment standards to you this morning. These are vitally important standards for our services, and obviously they came from the inception of the task force in 2019. September 2019, Scottish Government commissioned a task force to look at the tragedy of the level of drug death in Scotland. So they've been working behind the scenes to produce these standards, 10 standards, which we will go through in some detail with you this morning. But I think actually the standards we will be self-assessed on in future inspections. They are vitally important to the quality of our services, to ensure that they're trauma informed, to make sure that our services rapidly give people the treatments that they need. But that rapidity needs to be at no cost to safety, as Ross will allude to later on. So we've done a lot of work to date. We've assessed ourselves against the standards. We've put forward a bid to the Scottish Government for additional investment to help us to embed the standards, because it's very, very ambitious. The standards have to be fully operationalised and embedded by April 2022. That is no mean feat. So we're going to take you through the standards so that you know that we fully understand what the challenge is ahead. Before I do that, the principal reason the standards are here today is because of the level of drug death. And I would just remind the committee of the level of drug death that is current as of today. The level of suspected drug death in Forth Valley today is 41. 41 individuals have died too soon and actually potentially could have been prevented in terms of their deaths. So that is 20 people in the Falkirk area, 10 people in the Stirling area and 11 people in the Clackmannanshire area, all suspected until confirmed, predominantly male, but each a tragedy for them and their families. So over to Ross for Standard 1.
Thanks, Elaine. So MAT Standard 1, picking up on what Elaine said a few minutes ago about rapidity of access, is designed to ensure that everyone presenting with a need to have medication-assisted treatment is able to access that on the same day of presentation. This standard is often referred to as the jewel in the crown. So this is the one that really is going to challenge our services and really is focusing our minds about how we need to change the configuration of services and how we need to work together across all health and social care services to make this a reality. At the minute, our position is that we do achieve same-day MAT for people that are restarting on medication. So that's for people that had already had an established prescription and for whatever reason had come off that script and stopped their treatment. So when those individuals represent, we've got a reasonable success rate of achieving same-day restarts. We provide rapid access for people that are admitted to our hospitals. So if you're in the wards, then access is not an issue, and we can certainly do that on the same day that we see you. However, at the minute, our services are designed to respond to a 21-day target, and it's 21 days from the point that your referral's received. So that's quite a significant departure from the same day. Now, what I will say is that the clarity around what the same day mean isn't exactly fully understood yet. So we don't know if same day is within 24 hours. We don't know if the clock starts at the point that you see your GP as opposed to at the point where you see somebody in the specialist service. So we're still feeling our way through that, and we're working with colleagues at a national level to understand what that's going to look like. But we're not letting that hold us up in terms of starting to make some changes and make some progress on this. Whilst the MAT standards have been in development, we've been working on our prescribing guidelines to make sure that they are fit for purpose and fit for prescription. And now that the MAT standards are here and we've got them in our hands and we're working on them, we're going over our prescribing guidelines again, just to make absolutely sure that the way that they're written doesn't inhibit us from achieving these standards. So we're having to go through all of our guidelines to make sure there's nothing in any of them that says, for example, that you need to have a drug test on day 1 and day 7 before you start on MAT, which was historically how it was set up. So that's a fairly significant bit of work that we've started already. There are a number of challenges in this, and Elaine alluded to safety being something that I was going to bring up as we went through this, and certainly rapid access to treatment can't be in place of safe access to treatment. So there are some cases, not a lot, but there are some cases where it wouldn't be appropriate to start people on medication on the same day as they present, and we need to do a much deeper dive into their case and understand the risks and put some risk mitigation in place first before we start people on medication. So that goes back to why the prescribing guidelines and why all our clinical guidelines really need to be sense checked to support this. This is absolutely a major change in practice for us. We need to map the patient journey and make sure that we can get the flow as good as possible going through our services. And at the minute, I think there's room for improvement there. We need to make sure, as I've already said, that we have really robust guidance for our practitioners so that the clinicians know how to safely prescribe medication when people present on the same day. And ultimately, this is going to require a significant degree of workforce planning and importantly, workforce development. And we'll come on to that in later slides as well to make sure that this is safe and achievable. We've already started our project team for MAT Standard 1. We had our first meeting last week. We are supported in that by the PMO and Forth Valley Quality, and we're taking a quality improvement approach to doing that and tying that work in with the work that we've already got going on our pathways and our value management collaborative work. We've made additional requests from MIST, which is the MAT Standards Implementation Steering support team at the Scottish Government. So we've made some asks of them around additional support that we can get as well. So we are on the move with this. We have started, but this is a significant bit of work that will take some time to achieve. Moving then to MAT Standard 2. So this sits very neatly along with MAT Standard 1. So this is about making sure that people are supported to make an informed choice about what medication to use for MAT. So historically, you heard MAT or you heard opiate replacement therapy, you thought methadone, and everybody thought that that was the only show in town. But there are options available for people now, and the most significant option or the most significant development that's come along in recent years in terms of options for treatment is Buvidal, which is an injectable form of buprenorphine, which means that patients don't need to attend chemists every day to pick up prescriptions, and it gives there are a number of benefits along with that. So we want to make sure that those options are available to every patient that presents to our services. So we have currently got a formulary that's inclusive of methadone and both forms of buprenorphine, which is not the case everywhere. We've actually moved beyond the pilot phase of Buvidal. So we did a trial of Buvidal, and that was really very successful. And we've now got about 40 patients on Buvidal across Forth Valley services that are doing well, and we're looking to develop that further and roll it out more broadly. We're working with colleagues at a national level to optimise the patient information leaflets, because obviously making an informed decision about your medication means that you have the information there to do that with. So we're working with colleagues nationally to refine that. One of the things that comes along with these standards is that we need to be able to report on our progress, and one of the measures for MAT Standard 2 is the ratio of people on methadone versus buprenorphine on either form. So at the minute we are working on our reporting systems to enable us to give that information readily. So we can mine for the information just now, but it's not readily available, and it really needs to be available to us in order that we can use it for improvement and change. Of course, there are challenges with this. So with a change in practice and the introduction of Buvidal particularly, that requires quite a significant amount of staff development, not least the understanding of the pharmacology that goes along with Buvidal, but the actual act of administering the medication. We need to make sure that staff are trained and competent to be able to do that. So that's ongoing, and we've got some staff set up and able to do that, and we've established some clinics, but there's more work to be done there. The costs of medication is something that we need to wrestle with. So we have additional support from Scottish Government to help us implement Buvidal, but the cost of Buvidal versus the traditional methadone or oral buprenorphine, they're not equal. There are savings and there are ways to make it work, but they're not equal. The important thing here is that we are not refusing anybody access to treatment on the basis of cost. So we are able to provide Buvidal just now to patients without having to consider what the costs are. But for those of us in the service management seat, we need to have our eye on the pound sign, and so that will be something we need to monitor going forward. Forth Valley Recovery Community are engaged in some peer-led research so that we can get some really meaningful data and understanding about what the patient experience is of being treated with Buvidal as opposed to the other traditional ORT medications. And I'll seamlessly hand back to Elaine for MAT Standard 3.
Thank you, Ross. Just before we move into MAT Standard 3, we have to point out to the committee the challenge is steep for 1 and 2. Capacity-wise and resource-wise, we have a challenge ahead of us with that. But Buvidal is life-changing for drug users. Not to have to traipse to the pharmacy every day to be able to, keep yourself right is absolutely life-changing. And the pilots that we've undertaken in prisons has demonstrated that we're ahead of the curve with that. So we want to continue with the patient choice regardless. And try to make sure that our patients get the best from the treatments. MAT Standard 3 is about proportional response to the high-risk drug users. We have approximately 3,000 drug users in our area. There are 1,200 approximately on opiate substitute therapy, MAT, whatever acronym is the order of the day. So you can see there's a gap and with that gap there is risk in untreated need. So we need to find, seek and treat these individuals in whatever way we can. And believe me, we are definitely trying our hardest to do that. Latest things that we've got in chain is a peripatetic outreach team who will tag to these individuals on the next day that they suffer an overdose and seek, treat and engage them in service. So that will be in place by the end of the autumn if recruitment goes well. Recovery community will be the foot soldiers, the high level skilled nurse will be the leader, and we hope to have a social work element to that team as well, to be able to seek and find everything that is harming the individual and their families. In recent times, we've increased the capacity in the hospital addiction team to 7 days. We've brought on a suicide and drug-related death prevention coordinator, a drug death prevention investigator. We brought on prisons transition plans to be able to, for those who are released from prison on a Friday, when usually that leaves them absolutely with no choice other than to use illicit drugs. We're sorting a pathway from highly used prisons in the area. So there's work in the acute hospital to fully initiate referral processes and to give naloxone. I have to tell you that the naloxone in ED is sector leading. It's sector leading. That is not happening in every hospital in Scotland, and indeed it probably is not happening in many. So these are the innovative things that we've brought forward with the support of leaders to be able to change the outcomes for people and reduce the risk overall. We also are bringing on a hub that will look at the wider health implications for individuals whose health is usually not good because of a lack of engagement and everything that we can do to prevent and protect them. So all of these things collectively will make a very big difference. So hopefully we'll be able to report back to you in a year's time to say that, you know, all these things are in place and we're seeing an improvement. Thanks, Ross. One of the key risks for drug users is bloodborne virus. And bloodborne virus, we have another mission to be able to clear the hepatitis C disease, to eradicate it indeed. So we must make sure that every drug user is tested and that they can get the appropriate medications with minimum side effects now that they can help to clear the virus. So to do that, we also need to make sure that their venous health is good. So we must make sure they have appropriate equipment and technique to be able to inject safely. It's not a palatable option to everyone, but it's necessary for drug users. So we have to make sure that injecting equipment is available in our services. Now, that's maybe difficult to hear because actually you might imagine that your needs were met, but actually it's not. Some people's urge to inject is still there, so we need to walk alongside them with that. We need to make sure that they've got everything to reduce harm. We also need to make sure that for female drug users, they exercise all of their options to delay the onset of pregnancy, to reduce the cycle of harm that's caused when women are actually finding themselves pregnant and they haven't planned it. And this is all about person-centred choice. There's nothing controversial about it. It's about women exercising their choices. Thanks, Ross.
Okay, so MAT Standard 5 was the subject of a bit of debate in the development of the MAT standard. So we, along with most other boards, gave feedback about these standards when they were in draft. And one of the things that we fed back quite strongly was that the wording of this standard doesn't really support a recovery focus, and that patients are encouraged and supported to remain in treatment for as long as requested. It's probably not the form of words we would have wanted. Nonetheless, that is the standard, and that is what we're working to deliver. So currently in our services, access to treatment is not time limited. You don't have a set period of time when, if you've not stabilised or you've not reduced, then it's game over and it's time to move on. Our treatment and care is always person-centred, and it can go on for as long as it's needed to. To support that, we have prescribing and key worker guidance, and we've got a very robust recovery model and work closely with our third sector partners to ensure that all the bits of the jigsaw come together to support that. We've started work on our pathway to maximise the efficiency and capacity in our service. So we need to make sure that people are seeing the right person at the right time. And that's not a new concept, but we need to make sure that we're really making the most of that. Because if patients are going to stay in treatment for a protracted period of time, then the service is going to fill up quite quickly if we don't have that throughput. So we really need to keep the recovery focus here. And in order to do that, we need to keep our eye on motivational interviewing as a really key intervention for people who maybe have plateaued in their treatment and aren't motivated to move on to the next stage, or aren't motivated or able to be able to move into more high intense psychological interventions and treatment. We need to make sure that we don't miss any opportunity to intervene and promote recovery and improvement for that individual. That will require workforce training, and of course, I've already touched on, but when I was talking about the capacity of the service, capacity will be challenged by people staying in services for longer if we don't have that throughput. So we need to keep an eye on that. We've already re-established our motivational interview and peer support group to support the staff to develop their skills in that.
The standard 6 is one that we feel we're quite strong on. Our consultant clinical psychologist in addiction has been on the national group and is advising the task force on this. So this is about being trauma informed as well. So we want to make sure that our environment is trauma informed. So for example, our consultant has been doing trauma walkthroughs to make sure that there are no triggers for individuals who use our service. We need to get a culture of coaching in our services to be able to, as Ross said, move people through, and not ever to consider people to be stuck. It's just maybe the opportunities haven't been shown to them yet, or they've not been exposed to everything that they possibly can be. So this is one of the standards that we're least worried about because we have been in the development of that nationally. Thanks, Ross. Primary care is absolutely critical to us, and in our area we are lucky. We have had a local enhanced service with our GPs for opiate substitute therapy since 2005 perhaps. But it's not for every GP. It's not we offer them support and training, and indeed we pay them to work with us on opiate substitute therapy, but we need to increase their repertoire in terms of Buvidal training and support as well. So with the GP lead, I will be reviewing the enhanced service next year to be able to include that, and we would hope that GPs might have an increase in their local enhanced service payment for that. But general practice is really important for patients to be seen and treated by their own general practitioner safely at the right tariff of patient is critical to recovery. And actually for general health issues, testing, treatment, prevention programmes, to be closer to primary care is better for the patient. So this one we'll need to build on. We have approximately 18 practices engaged in Forth Valley. That's good. That's not the same across Scotland. So people are now coming to us to ask for our enhanced service to be able to see how we've managed to do this. But the GPs that we've had for years, some have retired and moved on. We need to encourage the younger GP, not being ageist at all, but any GP actually, or the newly qualified GP rather, to come and work with us on this. And we'll need the support of leaders to help us to do that. Thanks, Ross.
So Standard 8 is about patients having access to advocacy and support for housing, welfare and income needs. Most of our services already would say that they advocate for patients and they direct patients to these services, and certainly within the services that we've got, I'd be fairly confident that staff are able to direct patients to these services, but that's quite different from having them embedded in the services and having really clear pathways for access. So that is a bit of work that we need to take on. That's what we need to do to achieve this standard. We already have recovery workers within Falkirk Housing, so that's a good step ahead. And although our staff are already would consider themselves probably advocates in many ways for patients, we need to really understand the commissioning model for advocacy, because at the minute our understanding is that is fairly restricted for patients that fall into specific brackets around about detention. So we need to revisit how we've commissioned advocacy to make sure that is accessible to us. Some of this will be picked up, and we are in our pathway. So we've started work a couple of months ago now on an end-to-end path for people presenting with drugs and alcohol problems, and some of the access to advocacy and these other things will be picked up in that. So we're on the go with it, but a lot of work to do. Standard 9 is about people who have co-occurring mental health difficulties and ensuring that there isn't a barrier to being treated for your mental health problem at the same time as you're receiving treatment for your addiction problem, and vice versa. So I suppose our position just now is that the substance use services are very much part of the mental health system. So CADS in particular has registered mental health nurses and consultant psychiatrists that run it. It's part of our psychiatric system, so it's already very much there. We have no impediment to being on MAT and being treated. So we have a number of patients that sit with both, for example, their community mental health services and our addictions teams, and they work together on that. What we have noticed over the last couple of years is that working relationship could be better, and there have been cases where we can learn from how we've managed things. It could be a bit more person-centred and a bit more wrapped around people's care. So over the past few months, we've been working on some guidance to support staff in doing that, and that is out for draft, or out in draft just now rather, for comment by the group that commissioned it. So this is really about bringing mental health services and all of those services that provide addiction support much closer together. And whilst we're in a good position, we have work to do on that. We could be much more cohesive and supportive around our patients. I've put the challenge in here being service capacity. I mean that because all of our services are extremely busy. So making sure that we don't drop the ball when services are so busy is a challenge. But actually, I do wonder if we get the joint working right, whether that would actually help us release some capacity, not just eat away at our capacity as well. And I don't think I'm being too blue sky thinking and saying that. I think that probably is a reality that we could achieve. And I'll hand you back to Elaine for the last one.
Aware of time, I'd like to say that we are confident that in this MAT Standard 10 that we are good at this. We are good at developing our workforce. We are well advised by psychology. We have good supervision practice. So there's not a lot more to say about that, and we'll be able to evidence that in any inspection. Thank you very much for your time.
You're on mute, Fiona.
Oh, gosh.
Am I on mute now?
No, I heard you there. Could hear you there.
Right, so it's just toggling itself on and on. Thank you. That was a really interesting presentation. So I want to open up questions, but just to note in the chat that Elaine said that there's a good practice session on the 17th of September, which members may wish to attend. So Elaine, if you can maybe share that would be great.
Yes.
I've probably got loads of questions, but I'll just ask one quick question around the injectable Buvidal. I know what you said, the benefits apart from not having to attend pharmacy daily, but I just wondered what were the other benefits, because you were saying the pilot had gone really well and it had been a great improvement for the people who were choosing that option, and I just wondered if you could maybe comment either or Elaine.
I can start with that. There's a lot of stigma attached to attending the pharmacy, and a lot of disruption to life as well. So if a patient can go about their daily life without being confined to the time frames of going to a pharmacy, being watched as you consume your medicine, I can't imagine how embarrassing that might feel for people. That's one of the key benefits, Fiona, for people to be able to live their life in a very normal way, but we'll also be able to talk about the clinical benefits of that. And there's also they can't trade it with others. So there's a safety aspect as well, because it is currency. Opiate substitute therapy can be currency and it can be illicitly traded. So that prevents that kind of thing as well.
Thanks, Elaine. So I suppose, so from a clinical perspective, this is an injection that you get once a week and then once a month, once we've tested it out. So you're getting through that mechanism sort of a stable concentration of the drug in your system, so you don't have the highs and lows when you get peak and low plasma levels, which means that patients don't experience fluctuations in the effects of that medication in them. Much more stable state. So it's much easier then to live a normal life and go about your business. We've seen, but because it is a monthly injection, you get it once and that's you've had it. Compliance with treatment is much better. I know the word compliance can be a bit emotive, but I mean compliance in the sense that the medication's been taken as it's intended and designed to be taken. So you don't have the risk and you don't have the worry of people missing doses and things. And as Elaine's alluded to, there isn't then a currency, so there isn't a trade. You can't pass it on. Particularly in our prison settings, that's been pretty revolutionary. So that's taken away a lot of risks in the prison setting, but it's equally as pertinent in the community. There are risks of patients having take-home medication as well. So if you're sending someone away from the chemist with 2 days of methadone or a week's worth of methadone, then there are risks associated with that, and it removes all of that. But ultimately, I think the biggest one here is the one that Elaine stole my thunder with, which is the fact that this is really destigmatizing and revolutionary for patients who can live a normal life without being tethered to a chemist and all the stigma that goes with the methadone patient coming in to get that.
Thanks. I'd like to questions, and Margot's got a question.
Right, can you hear me?
Yeah.
Just to say, it's a comment, and it's a comment on behalf of service users, because obviously this is very exciting and very beneficial, and it was so good to hear such a full presentation on what's involved. And I too was very interested in the reduction of stigma and the reduction of risk by it all. And as well as benefiting service users, which is why I'm here, can I just also say this is very innovative and in line with the government's aims now to reduce the drug deaths, etc. in Scotland. So once again, Forth Valley at the forefront, I think. So thank you.
Thank you very much.
Thank you, Margot. Sarah, would you like to come in?
Thank you, Chair. Thank you so much to Ross and Elaine. I learned a lot from that presentation and really appreciate hearing from you both today. And certainly you both deliver it with confidence around the kind of best practice principles within this kind of methodology. I just wondered what arrangements there were. So this is about consistency across Scotland. It's very, very difficult to achieve. Local areas, we have different requirements and needs. I just wondered what the kind of national network looked like in terms of learning from one another and best practice, because there's a lot here to implement, and you've pointed out and outlined to us the resource challenges. So I just wondered what that network looked like, and there's opportunities for us to share our good work and also to be able to take from others, just to kind of support the kind of journey ahead around implementation. Thank you.
I'm happy to take that question first, if that's all right. So yeah, you're absolutely right, Sarah. We're a very small country, but with innovative practice in pockets. And we could be spending all of our time reinventing wheels when Dumfries and Galloway have got the wheel made. And that's wrong. So as soon as I knew that there was a team convened at government level who had looking at all the tests of change across Scotland, making the investments, bringing them forward, I wrote to them and said, I'd like to meet with you. You need to bring that to us, because we can't be starting things with such a small time scale. And it took a wee bit of time. So I went back again and again and said, we need this. You need to come and show us. Oh, we'll come and we'll do it for, and I thought, you'll come and do it for 1.5 hours to tell our staff and our teams what we need not bother trying to reinvent. Because, you're telling us, oh, other places are doing this. Well, how are they doing it? Because our service managers think that this is a steep task. So if they've managed to do it, I know that Ross would take on that methodology and think, I'll try that too. But we can't wait until we've not met the standards in 2022 to find out that Dumfries and Galloway were better than us. So they're coming on the 17th, armed with a good practice to tell us what other people are doing so that we can, well, pinch it and tweak it and use it. Because we're smart about that, because we definitely don't have egos enough to say that they don't know better than us, and they could learn a lot from us. They will pick up on what we're doing in our hospital. There is no doubt about that. So I hope that answers that, Sarah, and Ross might want to add something onto that.
No, I think you probably have covered it, Elaine. I guess we are keen to see what other areas are doing. That we all have the same challenges. So staffing across all the mental health professions is really, really difficult. So psychiatric nurses, psychiatrists, really challenging. So all boards are in the same position of thinking, oh, there's a steep amount of work to do here. So innovative practice in one area should be broadly applicable to another with tweaks. So we really want to engage in that. And really the ADPs are keen on keeping us tied into all of that. The drugs task force, of course, is coming out with things, but maybe not at the pace that we would like, and not with the clarity that we would like at this point. So.
For that, can I bring in Patricia now?
Thank you, Fiona, and thanks, Elaine and Ross. That was an excellent presentation and very fulsome in its content. So there's a couple of things that are jumping out for me. I suppose the first one is around that integrated and multidisciplinary team approach, and you did mention hoping to get social work input into that. I think it's absolutely critical that we do that. These are our vulnerable adults, and we need to be sure that we've got that full multidisciplinary approach and response, linking into our responsibilities, but also housing, homelessness, the transitions out of the pathways out of prison. Those should also be integrated and multidisciplinary. So I think we've got a lot of work to do, and we need to look at how we can, as a partnership, support this, but also facilitate some of the integrated working that I think is required. The other comment I've got to make is more of a question, is around the provision of safe injecting equipment and how we're going to do that across our communities. I'm very mindful of the attempts that Glasgow City has made to try and make that much more available, and aware of the clash between some of the devolved powers in that regard. So just interested to understand what plans there are locally for that. Thanks.
I'm happy to open that one up as well, Patricia, and thank you very much for your compliments on the work that's been done, because it's been a lot of hard work with staff to do this. So Martin is working with me on the team around the key components that social work could bring. So we're looking to see if there's solutions, because working across 3 areas might be a challenge. So we're looking at innovative practice around that. So we'll absolutely not forget about that one. Around the injecting equipment provision, all of the Lord Advocate's guidance around COVID, etc., and the availability of such things is all legalised in Scotland and is appropriate. We have excellent harm reduction services, both around the area delivered by CGL and in community pharmacy. I think maybe the controversy is around consumption rooms and heroin-assisted treatment. So that we did get a very small amount of money for, and the Director of Pharmacy and other Directors of Pharmacy in Scotland are looking at that. But that's a big piece of work, and actually, we need to carefully think that through. So we did get a small amount of money in the allocation for heroin-assisted treatment, but actually that's a different project altogether from the injecting equipment provision, which is entirely legal, entirely available and accessible in Forth Valley to reduce the burden of the bloodborne virus diseases. So I think we would need to convene as a wider Health and Social Care Partnership NHS group and leaders to discuss how we approach consumption of any kind or heroin-assisted treatment, because that will take much, much more money than we were being allocated. So I'll be coming back to you on that as a leader to say where do we go in the next stage of that one. But we need to bite the standards off and try to tick them off and then get to that one. If we get same-day access, our need for other things might reduce, but for some, they will want that because it's been publicised as being available, which isn't helpful. So we're not really set up for that at the moment, but we will be, and we'll get there with discussion, approvals. I'm sure about that, Patricia. So hopefully that answers that question, and Ross might want to come in on that one as well.
No, I think you've covered that, Elaine.
Thanks, Elaine. I think it was just important for us to understand that whole context that we're working in. So thanks for that.
Thank you.
Thank you. Can I bring in Stephen now?
Thanks, Chair. And again, thanks for the presentation. I know you, particularly Elaine, how from work we've done before, how passionate you are about this, and that comes across in bucket loads. So thanks for the presentation. I think my question follows on a bit from Patricia about integration. So the Samaritans describe drug-related death, alcohol-related death, suicide as deaths of despair. And if you look at Angus Dayton, the American suicide researcher, he calls them diseases of despair. So, nobody chooses to be an addict. And I think there's a lot of the drug and alcohol-related stats we're seeing, the highest, for instance, alcohol-related death rate since 2008, with a slight reduction in suicide. But I think there's a fine line between what is a suicide and what's a drugs overdose and what is an alcohol-related death. So, and then you've got the links into self-harm. And so I suppose going forward, yes, we have the standards here, but in general, that integration to look at this from a perspective of it's a nexus, whether somebody's addicted to alcohol or addicted to drugs or has suicidal tendencies or self-harm. So it's a bit of work for me about how as a partnership we pull all that together, because Ross is having been involved heavily in the crisis negotiator and using motivational interviewing, for instance, to create that way in which people can get to a table where they are prepared to accept help and influence positively their behaviour change. But the same tactics, I suppose, at work in that type of crisis and drug-related work across the spectrum. So I suppose going forward, how do we pull all that together so we look at this in a slightly wider setting as opposed to being very specific?
I'd like to come in on that just before Ross does, because it's really Ross's domain. But I entirely concur with your view that it is said internationally that a third of all drug deaths could be deemed as suicide. The hopelessness in the cases that I've reviewed, I can tell you that the individuals were on an end-of-life pathway with no end-of-life interventions. So that's tragic in itself, and it's inhumane. And we need to seek and find and engage them. But actually, having brought on from Public Health Investment the new drug death and suicide coordinator is a step in the right direction, because we will have a robust area-wide plan that will take in all of Falkirk's needs, Stirling and Clackmann's needs, and actually bring us together to unite to reduce this distress. I'm really hopeful about that, Stephen, but I'll leave it to Ross to be able to talk about all the complexity of the mental health distress. Thank you.
So how long have you got, I suppose, is the question. This is a big subject. I think building on what Elaine said, we need the intelligence about what's really going on here. And a big part of that is the staff that we've brought in over the last couple of months to start helping us to build that picture of intelligence. We have pockets of really a lot of knowledge around where the problems are and what we can do to get in early, but we don't have that big picture, and we need that to enable us to develop a strategy that's going to pull everything together and really make a difference. So I really think that is key. In terms of bringing mental health services and addiction services closer together and making them more accessible, I think we need to do that. Quite how we go about doing that is a piece by piece thing, and I think that what I touched on in the presentation was the work that we've already started between our statutory addiction services and mental health services to knit those much closer together. I think that's step one. We get that, and then we then move on to the next part and move them closer together. That there is a culture here that we need to shift. So this isn't just about changing a standard operating procedure. This is about changing the way that people think and people view suicide, drug-related deaths, addiction, and mental health as one big, as you put it, diseases of despair. If we can shift the thinking, and that's no mean feat, but if we can shift the thinking, then I think the services will shift at the back of them.
Thank you. Can I bring in Gemma, and then Roger, you can have the last question.
Thank you, Fiona. Not a question, I was really more just to provide some more information to Stephen's question there, so about some local developments around about just the issue that you were raising. So we have established a new subgroup of Adult Protection Committee, but also sitting across the Alcohol and Drug Partnership as well around Falkirk Escalating Concerns Group. And it's really looking at a lot of the issues that you raised. So it's a multi-agency subgroup. It includes members both from the Adult Protection Committee and the Alcohol and Drug Partnership. It includes housing, it includes health, Police Scotland, social work. And the remit of our group is to look at early and effective interventions. And a lot of the work that we're doing is to understand more about the crisis presentations to all the multi-agency services. Quite often that can relate to adults that are experiencing addiction and comorbidity through addiction and mental health as well. So we're looking to understand that a wee bit more, and we're also looking to unpick a lot more of the repeat presentations as well, to understand more about the needs of those adults as well. So that group is meeting locally 6 weekly now, and it's really just that we'll continue to work on those plans around escalating concerns for adults. So it relates to those who might be using alcoholic drugs, but it might be escalating concerns for other social care or health needs. And it's really just aimed to make it inclusive of all adults, because what we were recognising with adult support and protection, and it's probably the issue that you're highlighting with mental health as well, is that because there's criteria within these acts, sometimes adults who need support and who are at ongoing risk of harm are excluded from the interventions because they don't meet the criteria within those acts. So we're really looking to establish this group so that we're inclusive of all adults who are at risk. So that's a group that it's fairly new, and we've just established a new protocol. So hopefully we can develop as a multi-agency group and really sort of try and understand and unpick more of these themes and issues for adults locally.
Right, thank you, Gemma. I wonder if just going forward, if there's an opportunity to hear more about that development, because I think that's a really important one about identifying people at risk of harm, whether they meet the criteria for the acts or not. So I think that's really helpful. Roger, you'll get the last question.
Thanks. So working in the front line in this area, I have been pretty amazed at how the progress has been made in working both with mental health and the drug users. It's been really impressive progress, and I think most people in the front line have said that. But also, the frontline workers, I feel, are often, the progress is such that they're struggling to keep up and need a bit of more information and support to come along with that. And I think Stephen's point there, thanks Stephen for making that, I think that's a really important point. And you followed up on that, Ross, about a culture change being needed in services. There's still that aspect of this is a lifestyle choice. So people who've got addictions have got a lifestyle choice, and I despair at that, but we see that in too many frontline workers and managers, I'd have to say. Thanks.
Ross, did you want to come in there?
Yeah, just briefly. So you touched on a point that I didn't underline during the presentation. Actually, Roger, that is a really crucial point, and that is the pace of change and the ask of the staff that are working in these services. So the approach that we're taking around the MAT standards, and particularly illustrated around MAT Standard 1, is that we are taking a team approach to delivering this. We really need the staff that are working in the frontline services to be the ones that are designing and implementing the changes to help us achieve these MAT standards, because if we just write it all down and whisk them along, then as Roger's outlined, people won't understand and won't really get why we've done what we've done, nor will it stick. And it's a big ask that we're asking of them. So really having the staff at the core of this is crucial, and that at times might make us go a wee bit slower, but it will be for a longer term gain. I just really wanted to add that.
Thank you, Rosaline. You wanted to come in?
It's a small point, but it's really, really important. So we recently received an investment from government for drug and alcohol interventions. We hope that we will invest that in our services to be able to reduce the burden on the staff who have worked tirelessly through COVID and are still working through COVID and will probably have to work further through COVID with very high caseloads. But marked in all of this is unprecedented demand coming from new presentations. And these new presentations are predominantly female with alcohol issues. We had no idea when we carved out the CGL contract that this would skew the figures so much. So they have kept taking in and taking in and taking in to the extent that they are saturated, and it prevents Ross's service from transferring to the third sector provider. So we greatly need to invest in capacity in the services to deliver, if we have a hope of delivering on the standards, but equally to be able to address some of the need that's emerging from the trauma of the pandemic. So as IGIB members, you will probably be the people who will approve that very investment.
Okay, thank you, Elaine. Can I make a quick comment? I know you want to come in, Patricia, just on how we bring this together going forward. There's been some discussion around the integrated approach and all the different things that could form part of that, and how as this committee, but also as the wider IGIB, about how we can continue to receive information around that and be able to understand progress. So I'll probably be putting that into Patricia's hands anyway, but I'll bring Patricia in now.
I think it's been a really helpful discussion today, and I think the work that we've done to align with Adult Support and Protection Committee, the ADP and this committee is really starting to bear fruit, but we really need to take some action out of this, and you know what's clearly jumping out is around that support for frontline staff, for training, the work with primary care, but also really building on the good work around identifying those early indicators of harm and what we're doing with that, and that will potentially generate new or enhanced services. So I think it's really important that this work is commissioned, and that we carry it on. So I would suggest that we need to have something to the senior leadership team in the partnership to look at these strands of work, and I think Martin and Gail will support that work, but look at how we can actually pull this together into an integrated plan, that we're actually formally making all of those connections and looking at what's required in terms of training, but also delivery and also commissioning in terms of third and other providers.
Thank you very much, Patricia. I would thank you, Elaine and Ross, for the presentation and for answering the questions and so fully. I think we've gone slightly over time, but I think it's such an important piece of work that I think that's entirely appropriate. So thank you very much. I really appreciate it.
Thank you.
With that, I will turn to the next item on the agenda, which is the Whistleblowing Standards and Activity Report, and that's Angela.
Morning, Fiona. Morning, colleagues. Thanks for the ability to present this paper to you today. Apologies, I'm on a handheld device, Fiona, so hopefully you can hear me, and at least see me, which is a real shame, I have to say.
Yeah,
I'm
and you're tiny. You're tiny, but we can see you.
Well, I'm ably supported by Claire Peacock, and most colleagues will know that Claire is my PA, but she's got a development opportunity, I keep telling her, and she's developing the whistleblowing officer. So Claire is there, I'm sure, and will may contribute to things that I forget. Just wanted to say a couple of things. Colleagues may be hearing this for the first time, and for other colleagues who have heard this a few times, so apologies. I'll be very brief, Fiona. I just want to pick out a few points. The first thing I would say is that this is the first lot of reporting on this, and what you will see, Fiona, this will come through all of the committees before it goes to the NHS board, and in this occasion, just due to the timing, it's gone to the NHS board and some committees along the way. So, but it's in a groove of forward planning and reporting now, so colleagues will see this before it goes to the NHS board. The background of this, just very briefly, NHS England did a lot of work on Speak Up, and roughly around the same time as Duty of Candour, and they implemented their Speak Up standards, if you will, about 2016. And Scotland have been working on theirs over a period of time, and it was due to be implemented across the NHS in Scotland probably just in the spring of when the pandemic started, so it was put back. Then there was a thought that it wouldn't happen as the pandemic was chopping and changing. But the Cabinet Secretary made a decision that it would be implemented by April the 1st. And I'm pleased to say that despite that stop and start, NHS Forth Valley did significant work, and all staff and lots of people on this call really supported that, the chief officers in particular, with the other directors, and the partnership colleagues as well came alongside to make this happen, and we did manage to implement by the 1st of April. But you will see from the report there's much work to do, and this will take considerable time, but we do have and did meet the deadline of having implemented the whistleblowing standards in NHS by the 1st of April, and that was the ask of us. And a paper had gone to the board in March to approve the direction of travel as well as the implementation of the governance arrangements. So this report is the first report for Q1, and as I said, I have presented this to the board, and across Scotland everyone would have been presenting this report at the same time. So this report does two things, and I'll just briefly stop on both of those things, Fiona, and then I'm happy to take questions, and perhaps Claire will take any of the difficult questions. So there are two things: progress against the whistleblowing standards, and then the whistleblowing activity to date. So what we have done is managed to have an overarching delivery plan which allowed us to meet the deadline of the 1st of April, and we have managed to test these standards, because you will see from the report we've had 2 cases that have connected with the standards, and I'll be happy to give an update on that. We created an oversight group, and that's chaired by our whistleblowing champion, and Gordon has been appointed for that. Like every other board in Scotland has had a dedicated whistleblowing champion. We have an oversight group, and then in order to deliver the standards and develop the processes so that we could deliver the standards, we created an implementation group, and that's the governance and in terms of the delivery within the board. It also then, this whistleblowing must be reported to the board on a quarterly basis, and it must report through clinical governance, staff governance, partnership forums, and clinical governance and care and clinical governance forums along the way, and that's all in place from the outset. We had a dedicated implementation group, and they really initially developed the processes to support the standards, and the oversight group and the implementation group have saw the detail of these standards. And what I've tried to do in 2.1 in the paper, Fiona, is just show what were the key areas that we had to deliver in order to make sure implementation would deliver on the standards, and where are we in terms of the progress. So you will see that it's a fairly healthy progress report, but we are still at the beginning of this. And key to this will be staff training and development, and making sure that people feel prepared and comfortable both to speak up and to support people who wish to speak up. And I think it is a large cultural piece of work and an OD piece of work in the truest sense. So we are only at the footholds or the footholds of that process. We will have to make sure that there are confidential contacts, and what we have in Forth Valley, similar to other boards, is combine that with the Speak Up model work. NHS Lothian again has piloted this just a bit ahead of the rest of Scotland, and they've spent some time with our HR director and colleagues and our partnership colleagues to understand the Lothian experience. And recently the Speak Up model has been developed and approved by the NHS board, led by the HR director and the employee director, and we're currently in the process of recruiting to both Speak Up champions, and they will also double as the confidential contacts. So when all of these people are in place, it allows the standards to be complete in terms of the whistleblowing standards. There is an implementation group, and they are focusing very much so on the delivery, the communication and the training and development, and we're hoping to have a much deeper launch just in the autumn time around raising awareness and supporting staff via a kind of a toolkit or a staff guide that will have everything in there that staff will need, both to support one another, to support the training and development, and to support people who feel that they've got concerns but they're not being listened to via any other means. In terms of section 3, whistleblowing activity, you will see that now I am on holiday, so I don't know, Claire might tell me if there's been any other cases, but at the moment we've only had 2 live cases which are being considered and investigated. One case was somebody external on behalf of a member of their family who's an NHS employee, and that was already being dealt with through HR and organisational processes. And the whistleblowing guardians would come together to make sure that the whistleblowing standards are adhered to correctly, and they decided that that was much better sitting under HR policy, and the individual is aware of that. The second one was a staff member speaking up about the quality of care in a clinical area, and that was investigated under stage 1 of the whistleblowing process. Now, as soon as we had the concerns raised from the individual, we immediately started an investigation, as we would do with anything, Fiona, and then we supported the colleague who wished to raise concerns through the whistleblowing process, and that has been completed in time, and we have had follow through with the individual to make sure that they are comfortable with the changes that have been made, the approach that we've taken, and the information that we fed back to the individual who raised the concerns. We have, as I said, investigated the concerns anyway, and we've done lots of follow through, unannounced visits, supportive to make sure that everything in the delivery plan for that area has been focused on and completed. And I'm pleased to say, Fiona, that has been. This report would develop quite significantly where there is lots of activity in relation to whistleblowing, and at the moment the whistleblowing activity is small, so you're not seeing a fulsome report, but in time you'll see a very similar report to the complaints type report that we have, where you're seeing the issues and the themes, you're seeing the actions taken, the learning, and that will develop over time. We have, and you'll see from the paper, there is a module that captures the whistleblowing activity and will give us deep reports and feedback, as well as helping us to adhere to timelines. That's part of the current safeguard system that we do with use for complaints and other significant adverse events, and that's got the capability to report, as well as the KPIs or the indicators that you will see in Appendix 1. So in terms of my final 2 comments is to say that there is much to do. We have met the timescale in terms of the implementation, but you can see through staff training, communication, and building the confidence around this process, including where to go to if you've got concerns and you want to be supported through the process, is all in hand in developing, but it will take time. And key to the risk assessment for me is staff feeling that this process is fair, that it does what it needs to do, and that staff feel that people are taking it seriously, and any learning and changes happen as a result of that. And some of that will take time, but that features within the risk assessment of this work. It's very much staff led, and in terms of improving services and the conditions in which people are working in. And I think lastly, the key indicators, you'll see a more fulsome report after the next quarter, where we've got more data to support the key performance indicators. Gordon keeps us abreast of all of the national work, because everybody's learning and developing this at the same time, just so that there's not any to avoid duplication. But I think we're all duplicating at the moment, I must say. And lastly, this has got to cover staff working in NHS facilities and working for the NHS in other areas, and we're really only at the foothills of that in terms of making sure that the processes work. But the chief officers in particular, and the other directors who sit with staff slightly outside the NHS in that regard, are really guiding some of the activity around that to help us get some of that work done at pace. But I'll pause there, Fiona, and I'm happy to take questions. And I don't know whether Claire wants to add anything. Just given that I've been on holiday, I may be behind the curve. I'm happy to be updated. Thanks.
Thank you very much, Angela. Claire, I'll give you the opportunity just now if you want to add anything in.
I think Angela's probably covered everything, nothing else to add, and no other activity to date.
That's great, thank you. Thank you very much.
Thanks, Claire.
That's a really helpful report, and obviously very important policy to have in place, and very important support to have in place. I suppose sort of going forward, that question about that integrated space and how that staff working in integrated services but employed by the NHS, and how we get information around that, and how staff are supported within that is probably one of the key questions I would imagine from this committee.
Yeah. Absolutely. I mean, Patricia may want to say something, and I guess as well, Fiona, the whole of the country are, even in the consultation around these standards, people were really grappling with how did that work? What's the complexities? And certainly Patricia has kind of led the charge in that, and it's been really good for particularly my chief officer colleagues to kind of be really active in that space. I've got to make sure that it happens, whether it's in universities, whether it's obviously we've got a huge amount of staff to be transferred in terms of Circle, so it's got to work for all of our partners, and we are at the foothills around that, but we're hoping it will be a very streamlined process. And in relation to it should be a simple process, but in relation to the whistleblowing, it can cover both business as usual as well as a true whistleblow. And what's really important in that space, so if it was a colleague that was working in the Falk partnership, Patricia and her team would be involved in the very beginnings of that in terms of how it's handled and how we do that. But I have to say, even in the one case that we've supported a colleague through where there was concerns about clinical care, there was a huge amount of learning in that and changing and tweaking our processes. So I think this will be probably, as I said, organisational development in its truest sense over time, but we are speedily changing things as we go. And I think this will be the most tricky area in terms of in the integrated in the spaces, people who are not directly working in the NHS space.
That's great, thank you very much. Do we have any further questions or comments? Stephen.
Thanks, Chair. Hi, Angela. I mean, I know there's a lot of effort being put into this across the whole of the NHS, but we're not seeing a great uptake. I know government are, kind of KPIs around about this, going, what's going on, and you've explained the kind of general plan there. Is there anything we need to be doing, I suppose, immediately in terms of encouraging staff to speak up? I mean, I think Greater Glasgow reviewed a lot of their complaints and felt there was a fair amount in there that probably should have been come through whistleblowing. Is there anything we should be looking at locally, other than what you've already said?
Yeah, no, thanks, Stephen. It's a fantastic question, and I guess I'd probably, and I can come back to Glasgow because I guess I've been there when they've reviewed their whistleblowing process, because that was connected to the infection control area that the government had asked me to help out on. So got a lot of insight track. I think the first answer is that if we are working well as an organisation, it didn't matter which organisation, the whistleblow should be the very last option. It's important that it's there, and it's important that people can use it. I guess the kind of speak up model is designed to try and encourage and bolster the confidence and the culture around speaking up, and trying to understand why people are not raising it in certain ways. I think some of the learning is where people have already raised things and they've perhaps not been dealt with in a way that staff have felt that made a difference to patient care or to the team that they were working in. I think there's probably a lot of learning from that. I think that came out from Glasgow. I think that might be some of the connection that you're making as well. And then I think for us locally, and I guess nationally, it's so new. I think everyone had to have a sprint start really to get to the first, because I think the indications were that the Cabinet Secretary was going to put it in abeyance for the rest of this year. So I guess we've kind of rushed forward, Stephen, but what we've not really got is it really implemented in terms of the depth. What I'm hoping in through September and into autumn is that we do communication, we up the training, we really work with the directors to make sure that their colleagues are all having, raising awareness and training, that it's training online. And I think with the launch of the Speak Up champions and the confidential contacts, they will be starting making connections. So I'm hoping with the comms, the training plan, raising awareness, the kind of staff handbag or man bag that we've developed, which is a kit with everything in that you need to know to either support or to raise concerns. I think if we're going to see something, Stephen, we'll start to see it when those bits are really working. I think at the moment they're there, but they've not really got the depth yet. And I guess if we are, if we live to our values, we respect people unconditionally and we have mutual respect, we treat people well and we've got good team working, you would hope you might not need those things. But if we don't have that and people are not speaking up, and that's a very different thing. And I think that's what I'm most alert to, Stephen. So not answers yet, but I think plans, and also I think there's a real will around this in the organisation as well. I've been astounded that people came alongside us and worked so quickly and supported Claire and the implementation group to make this happen in such a short space of time, and that was staff power that did that. So there's definitely interest, Stephen. It's just how we capture that, but time will tell. But yeah, it's the $1 million question you've asked.
Thank you, Angela. I don't think there's any further questions. So thank you very much for the report. Thank you very much for joining us from your holiday.
You're entirely welcome.
So I shall move on to the next report, which is the hospital-acquired infection performance report, and bring in Jonathan.
Thanks, everyone. I'll let my team do well.
Thank you, Fiona. So yes, thank you for the opportunity to present this. This is the quarterly report for April to June this year. So I'll quickly start off about COVID and where we are, where we finished in June, and I'll give you a little bit of an update of where we are at the moment as well. So towards for the quarter itself as a whole was quite quiet in terms of COVID inpatients, although we did towards the end of June see a start of the increases in infections, and we're now sitting around about 20 inpatients currently. Now this is about average. We've seen this now probably for the last couple of months, ranging from the mid-teens up to the early 20s now. So we haven't seen any significant increases since then, which is encouraging. We don't know, since the schools have returned to, we often find there's a lag of when something happens, like changes in restrictions and what have you. There's usually a couple of weeks time lag between we see the impact of this within the hospital setting. So we're mindful about whether or not we will see increases in hospital inpatient activity due to COVID over the coming weeks. But again, we're monitoring this, and I'm hoping that won't be the case and will remain at these levels.
or to go down. In terms of the rate of our hospital-acquired infections of COVID, now this is something that we report on a weekly basis to governments, and this is based on people developing infections after admission, and they use the day 14 as the cutoff for identifying hospital-specific infections, because obviously the incubation period of 14 days. And our rate at the end of June was 1.3% compared to the national rate of 1.5%. And I can just give you assurances that our rate now has fallen to 1%, and the national rate has also fallen, but it's still higher than us at 1.1%. So we've over the whole pandemic, our hospital acquisition rate has always remained much lower than the national rate, which is also encouraging. Throughout the COVID period, as you're aware, my team have been providing support to care homes from an infection control point of view. And just to give a quick update on that, nationally, there's been an infection control manual specifically designed for care homes, and that's been rolled out, as well as cleaning specifications as well. That's to provide support to the care homes and to provide them with some literature and also guidance about what's expected. The care assurance, the care inspectorate will be monitoring compliance to this, I believe, from next month onwards during their visits. We are actively providing support to them. We have recruited staff. We had some interviews, last week, and we're hoping to have some staff, more staff dedicated to the care home setting, so we can provide support to them. In addition to COVID, we're now approaching the winter season, so we're looking at norovirus and flu and other just general infection control support to the work, and also the way we're developing a process of how we work collaboratively with the public health colleagues as well. So we'll keep you informed as things develop at the next meeting. Moving on to the annual operating plan. Now we have 3 targets that we have to achieve. The first one just I'll give you a bit of background on some of these. The Clostridium difficile infections, you're probably aware of that. This came on the back of the Baylor Leven inquiry, which you're probably all aware of, where there were high incidents of infection and deaths in the Baylor Leven Hospital, and as a result of that, that's become something on the national agenda. So we're mandated to report all our infections there, and also targets now have been set for reduction. We also have E. coli bacteremias. Now these are organisms, just to give you a very brief short course in microbiology. E. coli is an organism that lives in the gut. It's probably the most common organism that lives in the gut. And just to give you some ideas, there's 100 million of individual organisms of E. coli within 1 gram of feces. So it's not to be too descriptive there, perhaps, but it's something just to give you an idea that it's a high number within our GI tract. It's very common for causing organisms, causing infections such as urinary tract infections and so on. So, and we've seen nationally, right across Britain, an increase in this organism entering into the bloodstream. So we monitor bacteremias, which is organisms that are present within the bloodstream, and because of it's become the most common organism isolated from a blood culture. So nationally, they've put targets on these, so we need to reduce these. And also then Staph aureus bacteria is much the same as the skin commensal, and has also been associated with infections such as wound infections and particularly device infections. So if you have a cannula inserted, there's the organisms, because the skin commensals can cause infections as well. And we saw several years ago now, that this was one of the top organisms that was reported in blood cultures. Not quite this case yet, so historically we're still carrying on with this target. So just quickly go into the specifics of the targets. For the E. coli bacteremia target, as you can see on the graph, things have gone a bit awry in terms of our targets, but I'll go into a little bit more detail about that in our E. coli section of the report, and I can give you perhaps some theories and what we're doing about it to get these things. But in terms of our target for a 25% reduction, you can see the blue line along the page 5 is where we need to be heading towards in March. And certainly from the last results in June, on this report, that it's not quite in the direction that we were wanting. So, but again, I'll go into a little bit more detail about that in the next coming sections. For our Staph aureus bacteremias and our Clostridium difficile infections targets, I don't believe we're going to have any trouble in achieving these targets. So I'm comfortable where we are currently certainly to meet the target in March next year. So going to the specifics then, so Staph aureus bacteremias, we had 6 reported cases this last quarter, and that was compared to 10 between January and March. So again, we've seen a reduction, and only 2 of those cases were hospital-acquired infections. In terms of the hospitals relating to this committee, Falkirk and Bowness, there were no reported cases for this quarter. Device-associated bacteremia. So this is something just to give you an understanding. What I mentioned about the AOP targets are very organism specific. With the Staph aureus, E. coli, and what we found back several years ago, back in I think it's 2014, we started doing this. I did take the opinion that if there was a particular infection associated with, say, E. coli or Staph aureus, we would do a great deal of work around that. But if it was an infection of a similar cause, but a different organism, we decided it wasn't a requirement to do anything with, which I thought was quite. It wasn't as patient focused as I'd like to be. So we're the only board in Scotland that looks at all device-associated bacteremia. So we cover all organisms rather than specific organisms mandated nationally. So, and in terms of that, then, so our rates remain stable for the last quarter compared to the January to March. And again, just to highlight that our numbers within the hospital setting, we had 4 device-associated bacteremias reported last quarter, which is good. And just reassuring that there were no reported cases from Falkirk or Bowness hospitals. Our E. coli bacteremia rates, again, like I said, we had quite a sharp increase in our numbers. I do believe I mentioned this to you at the previous meetings, that we believed, because most of from our investigations, these were related to urinary tract infections or urinary catheter infections. And I made the assumption perhaps because of lockdown and its failures for patients or members of the public to seek medical interventions in a timely manner. And that made a lot of sense. We saw that in other aspects within the hospital setting. However, we've seen now a peak in June. And so we're looking a little bit deeper into why this is. I mean, we've only started surveillance in September 2019. So this is only our second full season, if you like, so we haven't yet got a good picture of the trends over years with Staph aureus bacteremias and the Clostridium difficile infections. We've got well over 10 years of data to have a look and see if there's any trends or not. So we're looking at E. coli and seeing where there are some seasonal trends, and we're doing a look back exercise on even quite simple things like temperature and things, because if you look back over last year, in April and in July and August, we had quite high numbers of infections, predominantly from urinary tract infections, urinary catheter infections. And we're wondering whether or not this is associated with dehydration. Certainly within the elder population, I can speak from a personal experience with my father. He would drink 2 cups of water every day, and that would be it, come what may, come rain or shine. And, we're looking at whether or not in the hotter weather, extra hydration is not undertaken, so everything becomes more concentrated and more likelihood of urinary tract infections and so on. So we're looking at that. We're doing a look back exercise on these patients to see whether or not they came in dehydrated and so on. So there's a bit of work that we're doing. So we'll hopefully be able to give you some more information on that at the next meeting. Clostridium difficile infections, again, as I said, we're going to be meeting our target. I'm certainly very hopeful for that, and our numbers are extremely low. When we only had 5 reported cases with 1 reported case from the hospital. Just like to highlight, none of these were to do with patient-to-patient spread. So it was all to do with antimicrobial therapies or people who are on antacid therapies, which can predispose the patient from developing the infection, because the organism is also part of the normal gut gut flora in about 15 to 20% of cases of the population. So reassuring, there was no cases of C. difficile infections in Bow Ness or in Falkirk. Just closing up to the report for our status and cleaning compliance. Falkirk and Bow Ness remain stable. Our Bow Ness hospital is we're in at 90%, and the estate scores for Falkirk are 89%, which is remaining constant. We do meet on a monthly basis with our estates colleagues and our domestic teams, and in fact there's one meeting going on at 11 o'clock today where we discuss the scores and to see where we can improve the environment and the estates work, so we can get the numbers back into the 90s as we would like to see. And finally, in terms of incidents and outbreaks reported, we had one COVID outbreak in Belsdyke Hospital, where we had one patient and 2 staff cases reported. Although we reported this because it was a cluster and we were mandated to report this to Scottish Government, we don't believe the cases were actually related, certainly not from the patient and the staff cases. And we've seen that now. We've got access to whole genome sequencing now, and we can actually identify whether or not each infection is actually related to one another. We didn't have it at that time when this outbreak, but from our investigations, we don't believe the patient and the staff were actually linked. Both staff members were asymptomatic, and we believe that they were incidental findings because we routinely screen all staff and all patients when we get an unexpected case of COVID within a ward setting. So I think that takes me to the end of the report. So I'd be very happy to take any questions if anyone has any. Thank you.
Thank you very much. That was very comprehensive. Really appreciate the detail that you go into on that. I suppose it'd be very interesting that the findings around E. coli and what you're looking at. I think the idea that it was about people coming forward later or not necessarily getting the treatment at the right time, timely treatment. I think it'd be interesting to see. And I too understand the idea of a parent who thinks two cups of water is sufficient. So I share your concern over that. Yes. So I'd like to open it up to any questions or comments. No? Well, with that, thank you very much. Okay. I shall move on to our next report, which is the Hscp complaints and feedback performance report, and I believe it's Mandy and Gordon.
Morning.
Good morning.
Who's going to go first, Mandy?
I'm happy to go first, Gordon. Yeah. So good morning, everybody. I'm just going to go through the NHS Forth Valley side of the complaints paper, and we're looking at Q1, so from April to June. Just to let you know that between April and June, there was a total of 7 complaints received by the patient relations team at Forth Valley. Out of those 7, 3 were managed at stage 1 and 4 were managed at stage 2. Stage 1 performance remains good at 100% and stage 2 performance dropped to 50%. However, that was because the family had requested a meeting with staff. So we've started our meetings again within patient relations. So that's always good to get the families in and try and do some face-to-face resolution with them. The top themes for April to June, the top theme was staff attitude and behaviour, where there had been 5 complaints. And then it was clinical treatment and then staff oral communication. The good news is that between April and June, we have received no new cases from the Ombudsman which relate to Falkirk Partnership. And there is just 1 case that continues to be open with the Ombudsman, which we're still awaiting a decision on. Thank you.
Chair, will I move on to the social work part of it? Yep. So if members look at their papers on table 1 is the social work adult services complaints, and you will see that in Q1 of this year, 78% of complaints, first stage 1 complaints, were dealt with within timescale. The performance the previous 12 months was around 56%, and we put in place a number of actions in Q3 to try and raise that. And you'll see from that table that in Q4 of last year and Q1 of this year, there has been an improvement. Now, I don't want to claim that it is evidence that we are definitely sorted the difficulties that we've been having in the past, but it is encouraging that we've had 2 quarters where stage 1 performance has improved quite a bit, and hope to be able to continue with that obviously into Q2 of this year. Stage 2 performance has dipped, but we're talking about very small numbers, and when you add stage 1 and stage 2 together, the average is 75% over the 2 quarters, and that's, as I said, that's up from about 56% last year. Table 2 just gives the details of the figures from year on year. You can see that performance improvement there over a longer time period, and I think it is important that we do look at things over a longer time period than quarterly, because there can be quite significant changes quarter to quarter. The next table at 4.3 is the outcome of social work complaints. I think the only item there that I would highlight is the increase in the number of partially upheld complaints. That's something that the partnership management team is going to look into further in the next meeting. You'll note that the number of partially upheld and upheld as a percentage is slightly increased. The number that are not upheld has reduced. And lastly, for just now, just to highlight that unfortunately due to staff absences late on in the process, I wasn't able to get a detailed breakdown within the complaints system. We physically have to go in and interrogate each complaint to understand what it's about. That information wasn't available to me at the time that I did this report, so we'll have a more detailed breakdown on that for the next report. But I think in summary, I would say that there are some cautious grounds for optimism about the direction of travel. We have put in place a number of actions earlier in the year, and there's some evidence that those have helped to improve our performance. Thank you.
Thank you very much, both. I have one question, and then I'd like to open up to other questions. Just in terms of the SPSO open cases, it seems such a long time between the original complaint and awaiting decision from the SPSO. Is that standard, or is that around COVID, or do we have any idea of when they might make a decision around that?
So I think the difficulty with this one is it's been such a complex case, and what I do know is that there have been 3 case reviewers that have been dealing with this case. So the last case reviewer, the newest case reviewer that's taken on this case, came back to us at the beginning of this year with a further 32 questions, which we had answered and sent additional information into the Ombudsman's office. They are working a bit differently at the moment due to COVID. However, I'm hoping, fingers crossed, that we actually get a decision on this case soon, because like you say, Chair, it has been going on for a significant length of time, and the complaint has actually been in our system for even longer than before the Ombudsman. So I think the family really need to get some resolution for this case. I would, I'm actually thinking about getting in contact with the reviewer to say, do you have an update on this one? Because it has been, it has been hanging about for a bit of a long time. So I'm happy to sort of speak to the reviewer and see if I can get an update for you for the next meeting.
Yeah, that might just, I think that would be really helpful, because you know,
Yeah.
your points about the family hanging on for this length of time, very pertinent, and, you know, in terms of the ombudsman making prompt decisions and understanding all the difficulties with COVID, you know, that still outstanding for that family.
And I think for me, it's more about, because I was the case holder on this case, and spoke with the family right at the very beginning of the case, so I know the distress and the anxiety this is causing them. So I think it would be really important for them to be able to get some closure around it as well.
Take care. Okay. Thank you. Is there any further questions or comments? No? Well, in that case, thank you very much to you both.
Thank
you. I shall move on to the next report, which is the overview of inspection reports and national publications. That's Martin, I believe.
Yeah, thank you, Chair. Members will be familiar with this report. It comes to every committee, and it really just highlights the outcomes from any national reports or any local inspection reports. The way the report's formatted really is we go into the detail of, I guess, the two most significant, in this case, the two most significant ones. So the first area that it really focuses on is the Mental Welfare Commission report, which was on the back of the themed visits back in April 2020. 4.3 of the report really just highlights the recommendations that came from that. There was quite a number of recommendations which really linked to NHS Forth Valley and all other health boards across Scotland. What the report highlights is the actions taken forward by NHS Forth Valley, or indeed the processes they already have in place. I think from looking at it, you can see they already had a number of actions in place and a number of processes. So in terms, I guess, of the Mental Welfare Commission recommendations, what the report really highlights is there are steps in place to address all of those concerns. The other area in the report that's given in detail relates to Burnbrae Care Home. Patricia said I would give you an update to what's in the report, but I'll basically go through the report first and then I'll provide that update. Members may recall at the last committee it was highlighted that Burnbrae had been inspected and that it was graded as weak across the board. In terms of the care inspector, that's a grade 2. And the reason for that low grading was that they had inspected us the previous year and given a number of recommendations which hadn't been followed through. That came as a bit of a surprise to the management team, I have to say, given that they had given the manager really clear directions around what was to be expected in terms of service improvements. I have to say, positively, when they came back to re-inspect, they did find that significant progress had been made. And actually the report that was published, when you read it, it was actually full of really positive comments about the change. However, there was some anxiety, I think, expressed by the inspectors around the risk of those improvements not being maintained. So they graded, at the time, they graded the care home as a 3 with a view to come back and re-inspect to see that those improvements had been maintained. They have actually been back, so we've, since the last committee, Burnbrae's actually been inspected twice. They were in towards the end of last week for an unannounced inspection, and the feedback from that, the early feedback from that, has been really positive. They found that we've met the only requirement from the previous inspection, as well as uphold the improvements from the inspection prior to that. So early indications are that they've increased the grades to 4, which is actually good, and that is really good progress for us, given the really short time frame between getting such a bad inspection and actually making those improvements. There was recognition that the leadership team had changed and that there was a real focus on driving forward quality improvements, and particularly in the areas of infection control. There were never any concerns around the quality of care, but there were significant concerns around a number of other areas, and so those have been addressed and they continue to be monitored. I have to say, I guess, part and thanks to the hard work of the care home assurance team, who have been working really closely with the home managers to make sure that those improvements are maintained. And I guess for the partnership to give us an assurance, an independent assurance that those improvements are being maintained and driven forward. The rest of the report then goes on to highlight, I guess, in less detail, a number of inspection reports that have been published in relation to other areas, none of which are really of significant concern. In fact, across the board, in the main, it seems that in terms of our care homes that have been inspected, overall there's a good quality of care provision, and there's a good quality in terms of infection control procedures and processes. You're about to hear about, I guess, some of the work from CHART, which will pick up on some of that. But I guess I would just want to commend the work of our CHART team in continuing to go out and make sure that the quality of care, particularly within the care home sector, is of a really good standard. That work will continue over the coming months. We are doing some work around the establishment within the social work adult service, and that will see the CHART team becoming a permanent established team within our structure. Because even if we do get out of a COVID environment, there is a real need to ensure that the quality of care within our care homes is good, and that is the real aim of that team. So happy to take any questions, but hopefully that gives you I guess some positive news, and hopefully it gives you enough of an overview. Thanks.
Thank you very much, Martin, and that's good news about Burnbrae, and I think even from the last inspection, some of the comments around the quality of care, I think were really important and really great to hear, and fantastic that the care inspector have seen the improvements made. I'm sorry, my dog's in the background making noise. So with that, I shall open up to any questions or comments. None, right? I'm going to quickly pass on to the overview of local oversight arrangements and mute and pass that on to Sarah.
Thank you, Chair. Similar to the previous report, this particular report comes to committee routinely, and it has the purpose of providing an overview of assurance and the local oversight arrangements that are particularly relevant to the Falkirk Health and Social Care Partnership. So today, committee are asked to note the contents of this report. Section 4 of the report outlines recent activity within the Public Protection Chief Officers Group, known as COG. The most recent meeting of COG was the 16th of June. At that meeting, Chief Officers considered the latest developments of the COG risk register and inputted their views about how it should progress. The ongoing development of this register is going to ensure that future meetings of COG are focused on the right areas of work, and both the Child Protection and Adult Protection Committee are working on their own risk registers, which will inform the overarching COG risk register. So this is a really positive development. Other items considered at the June meeting are outlined at 4.3. Section 5 of the report that you have highlights for committee that preparation is underway for the adult protection inspection later this year. We were notified of inspection on the 24th of May. We received communication from the Care Inspectorate that the Falkirk Partnership would be subject to inspection within the following 6 months. So the Adult Protection Committee has formed a multi-agency inspection group, and the remit of that is to ensure inspection activities are well prepared and responses to the Care Inspectorate are provided timely. The group will report routinely to Falkirk's Health and Social Care Partnership Leadership Group and into the Public Protection Chief Officers Group, and the chair of our multi-agency preparation group is Gordon Mackenzie. Section 6 provides an overview of the activity of clinical governance processes in Forth Valley. There's a couple of tables that are there for committee's interest. Table 1 detailing the reports and the updates and the presentations which took place at the most recent Clinical Governance Committee, and that's there to provide assurance of safe, effective, person-centred care. Table 2 provides detail of activity within the Clinical Governance Working Group. Care home assurance processes are outlined at section 7. The committee received a detailed report in February on Care Home Assurance Group. So this section of the report provides an update to committee on recent activity and the ongoing care assurance arrangements. Para 7.5, detail is given on the number of care home reviews undertaken and those outstanding. These reviews were requested by Scottish Government, and the chart team have employed additional resource to undertake this work. These reviews are ensuring robust review of resident views, outcomes, care needs, environment, family views, as well as importantly assessing the impact of COVID-19. Additional assessment tools have been created to ensure a robust scrutiny of COVID-19 visiting plans as well as isolation support plans as part of the pandemic impact. So there's a clear, robust and flexible plan that's in place for the completion of the reviews. Chart visiting information is provided at section 7.11. The data shows a total since November 2020 of 286 chart assurance visits. Point 716 importantly notes that new visiting guidance is incorporated into daily discussions and that there's work underway ensuring meaningful contacts for residents is being undertaken. So Chair, this report is for noting. There are a number of us at committee that can support answering any questions, and thank you.
Thank you very much, Sarah. I'll open it up. Questions? Stephen.
Thanks, Chair. Thanks, Sarah. See, just in terms of the numbers of the care home reviews, so I suppose, do we know what that looks in, like percentage figures? So I'm sort of struggling to get a sense of, is it 84 out of 2,500 or is it 84 out of 500? Would it be possible, I suppose, to look at those, I suppose, for future reports and kind of percentages to give a sense of that?
Claire, would you like to take up this question?
Yeah, that's not a problem. Yes, that's certainly something that we can do. I will break down the detailed figures. The initial overall figures, I think, as Sarah noted, were in the initial detailed overview. However, I'll bring that back with percentages just to break that down for ease. So thank you.
Claire, do we have any further questions? No. Okay, with that, thank you very much, Sarah. And we'll move on to our final item on the agenda, which is the Adult Protection Committee large-scale investigation. And I would just note that this is a public report. If any of the committee members would like to delve into information, has questions that would delve into information more deeply, then we would move to private session, I'd be advised if that was the case, but I'll pass over to Gemma just now for the report.
Thank you. So committee, I've been provided with an overview around our large-scale investigation review, both locally and nationally as well. Providing a summary there, and we're really asking committee to consider and comment on both that local and national activity, and note just a lot of the continuous improvement work and practice that has been carried out over the period that we're reviewing, and offer continued support with that with the various different partners. Provided a background there, and really just commenting on the increase in large-scale investigation activity, both locally and nationally, and given really a bit more information around the increase and some examples of good practice and the support of the new early indicators of concern group to support in this type of activity around preventing larger scale investigations as well, or recognition of the need to conduct one. Also within the report, we've tried to include some useful additional information at the foot of the report, which includes, Sarah had mentioned earlier, adult support and protection inspection. Appendix 1 details the quality indicator framework, where we'll be inspected around about our large scale investigation practice. We've also included in here an Appendix 2, which is the early indicators of concern framework, which we were really trying to embed within Falkirk, and we've been delivering additional training both to visiting staff to care homes from whichever agency that might be, and both the management and the staff members working within those settings. We've also provided a summary of the findings, some of the systems findings from the 4 large-scale investigations that have taken place over the period, and those are available at Appendix 3. And then finally, importantly, we've really just commented on some of the impact of the LSI process and the improvements resulting from our LSI findings. So some of that joint partnership work with the professionals conducting the investigations and the settings who've been subject to them, and some really sort of tangible things that have come out of that, including feedback from families and relatives, feedback from care homes managers, and some of the new resources and practices that have come on the back of the investigations and their findings. So really, just back to the ask of committee for sort of comment and discussion around about the content of the report.
Questions? Patricia.
Thank you, Fiona. It's a really helpful report, and it's really good to see the themes outlined. My question is about Appendix 2 and looking at the framework for early indicators of concern, and we've previously had on the agenda the whistleblowing policy, and it just strikes me that there is clearly going to be overlap between issues coming through the whistleblowing policy potentially and the early indicators of concern, and just wondered if you've given thought, I don't know if Angela's still on the call, but how we make sure that we are connecting and feeding through something that comes through the whistleblowing process into that early indicators of concern group. Thanks.
Yeah, absolutely. So the early indicators of concern policy and guidance, we'll have a reporting tool when somebody wants to submit an early indicator of concern, but then there's a really accessible guidance with it, and it's a stepped approach, and it does reference duty of candour as well. And actually one of the LSIs that took place over this period did begin with whistleblowing within an organisation. And we're really, the ethos with the framework and the ethos with the support that we're trying to build with all our care home settings is that there is this open dialogue, and the early indicators of concern framework is a stepped approach. We don't jump immediately to reporting concerns, we highlight them to whoever we're working with or collaborating with within the service, so there's the opportunity to discuss those, acknowledge those, and then react to them as well. So absolutely, and I think some of the reflective and improvement activities, so I mentioned in the report that we'd attended 2 of the away days, and very much the culture that we're trying to build there as well is actually, and we'd referenced this before within the group around some of the stuff about kind to remind, when we were thinking about, well, actually, if you notice something that isn't quite right, or we're hoping to have the framework and that table that's in the appendix visible in all our services who might be visiting these settings, but also in the settings themselves. So if somebody sees something, they've got a framework to position that within, and it might make that conversation a bit more easier I've noticed this, and I've noticed that it relates to the framework. What can we do about that? So I don't know if that answers your question, Patricia, but it is just about more of that dialogue.
Can I come back in, Fiona? It's just for staff, so that we make sure that they understand the pathways that they can go down in terms of raising an early indication of concern or of whistleblowing. So I think we need to give a bit of thought about the messaging around that, but also making sure that if something comes through whistleblowing that clearly would benefit from that action in that group, that there is a cross referral happening, notwithstanding the process will continue, but actually some of the actions that may be required could be best coordinated within that framework. So I think it's just making those connections across the different things, because for a member of staff, they need to understand the options open to them, but also I would expect they'd be raising a concern, wanting things to be better. So it's how do we really effectively get that improvement in place as early as we can. And so I don't know if Angela's still on the call or not, but I think that's an action for us to look at how we do that. Thanks.
Angela's not on the call anymore, so I think if we can record that as an action to be taken forward, because absolutely that makes complete sense about making sure that staff understand the different routes available to raise issues of concern. So we'll take a note of that for the minute. Are there any other questions or comments? No. Well, with that's our final item on the agenda, and I think we've actually made it bang on time. So thank you everyone for your attendance today. Apologies for the noisy dog. Hopefully it'll be quieter next time, we'll be a bit older. So but with that, thank you very much, and I hope you all have a lovely day.
Thank you.
Thank you. Bye.
Bye.